Hello, welcome to the audio lecture for Chapter 6. In this chapter, we're going to talk about health insurance, the major financial mechanism for the U.S. health services system. Okay, let's begin first with our introductory slide. Individuals have financial access to U.S. health services. Okay, that may be done by way of private or public health insurance. It can also be done through government-sponsored programs. So those may be the programs, for an example, Medicare, Medicaid programs, your TRICARE, anything that is sponsored by the government gives individuals access to financial services. Now, there are two categories in dealing with financial access, and that is one being risk assessments. So, risk assessments are those things that assess a person based on their age, whether they're male or female, what their economic background is, their genetic makeup, and then there's other factors that factor into that. The risk assessment is used to assess whether or not that person can get insurance at this rate, that rate, or if they need this plan or that plan. There are some insurances that require individuals to go through what we call medical underwriting. That should be something that sounds familiar to you if you've taken out or attempted to take out life insurance. Normally with life insurance, you have to go through what we call a medical underwriting department, and basically I put the definition here in the slide for you, and that's just where the insurance company needs to try to figure out what your status is as a person. For example, a person that is female non-smoker versus a female that is a smoker, you expect the premiums to be different. One of the things that you expect is for the smoking individual's premiums to be a little bit higher. Why? Because they are more prone as an at-risk person. When I say at-risk, meaning that that person is more prone to the lung cancer or TB or something like that, something that could be caused from the smoking, maybe develop asthma behind it or something like that. So insurance companies having individuals to go through a underwriting process gives them the information they need to determine, what would coverage be for them, what price should we charge them for the coverage, should we put limitations on the coverage, should we put exclusions on the coverage. Those things are done by way of the medical underwriting department. Next slide talks about cost sharing. Cost sharing is where you, the individual person, and the insurance company, you all share the cost of the financial services. Okay, now does that always mean that you're going to have a copay? No. Does it always mean you're going to have a deductible? No. Does it always mean you're going to have to pay co-insurance? No. Does it mean you're going to have to pay a premium? Yes. So with that being said, I put premium as the very first term on this slide so that we can understand what that is first, because if there's no premium, there's no reason in talking about a deductible or co-payment or co-insurance, because first a premium has to be established. So what is a premium? Basically, the premium is the fee that you pay in order to have the coverage for the insurance. How are premiums paid, or how often are they paid? When you go through your employer, premiums are paid by way of payroll deduction. Your payroll deduction, that depends on how often you get paid, whether that's every week, bi-weekly, or once a month. Regardless of what your pay is, your insurance comes out every time you get paid through that deduction. Is it cheaper to get your insurance through your employer? Yes, absolutely yes. If you choose not to take out your employer's insurance, it doesn't mean that you can't get health insurance, but what you're going to have to consider now is I should expect my premiums to be much higher because I'm not going through my employer, because that's just my choice, or you may have other reasons as to why that's not happening. But anytime an individual goes through the employer to get their insurance, even though you may have a high premium that's coming out of payroll, it's still a lot cheaper versus going to get insurance on your own. So you pay this Usually you pay it monthly, and like I say, you know, if you get paid twice a month or if you get paid once a month, you're paying that fee on a monthly basis, okay, through payroll deduction. Now, some individuals have insurances that require deductibles, and basically deductibles is that amount of money that you pay out before coverage is or before any benefits is paid out. I put it like that. Okay, so for an example, let's say for instance you have insurance and it is a $500 deductible every year, whether it's for family or if it's single coverage, it doesn't matter. Until you've paid into that deductible, your benefits are not going to kick in, and the insurance company is not obligated to pay any of those benefits until you've met your deductible. So what does that mean? That means, yes, you're paying your co-pays when you go to the doctor, and yes, your doctors get reimbursed what the insurance has allowed for the procedure or the test that's being done. However, you're subject to get bills every month because you haven't paid into your deductible. So you're pretty much kind of footing your bill. They're gonna, you're pretty much just kind of footing your bill or whatever. It's basically what you're doing. It's not that you don't have the insurance, but being able to pay those, but you got to meet the deductible in order for your full benefits to kick in. Co-payment. Co-payment is pretty much the amount that you pay at the time of service. That could be $10, $5, $15, $20, $25. It is an amount that is set by your insurance company. It varies from one insurance company to another. Okay? Then you have what you call co-insurance. That's just a percentage of what you would pay versus what your insurance pay. So let's say, for instance, you have a 20-80. That means you will pay 20%, your insurance will pay 80%. Or let's say you have 80-20. You will pay 80%, your insurance will pay 20%. So a co-insurance is based on whatever the percentage amount that is set by your insurance company. Whatever that amount is, that's how you will pay out. 40-60, 20-80, vice versa. Now, this is only paid after the deductible has been met and the copay. Okay, so if you have co-insurance, after you met the deductible and you paid your copay, and let's say you have 20-80, you pay 20%, and then your insurance company will pay the rest of it for you. Managed care. Health insurance is what is under an umbrella of managed care. Now that falls into three different categories. The first category is HMOs. These are your health maintenance organization individuals, and basically this is where you have a primary care physician who basically takes care of all of your health care needs. These physicians are from a specified network of individuals, and they're within the network that is established by your insurance company. The next group that we have under managed care are the PPO. These are the preferred provider. Basically what this means in a nutshell is this. You can go and see a physician, and your best option is to see one within your network. However, if there's a doctor or a physician that you absolutely love them, you love their services, you're used to them, but they're outside of your network, that's okay. However, you have to be expected to pay higher in your amounts because that physician is out of your network. So that's what preferred provider. Preferred provider is, this is who I prefer to go to. No, they're not in my network. Yes, I understand I'm going to pay more. Point of service is pretty much any care by your primary care physician in your HMO group. So you may be, they will cover, the treatment is covered by the primary care physician in your HMO group, but you are allowed to go and get treatment from a different physician, and you can still, for that visit, receive partial coverage. So a point of service says, here's your main primary care physician that you have been up under and he's treating you, but you've also getting treatment or being seen by a different physician, and so we're still going to allow you even partial coverage for that particular physician's services. So individual health insurance policies, basically these are the ones that are not covered by an employer. Individual health insurance policies are not covered by your employer. Basically, you are on your own. So you're either self-employed or you're just not in the workforce. Yes, they're more expensive. Highly, highly, highly more expensive. Commercial health insurance is that insurance that pretty much, an example of that will be like group health insurance. An example of commercial health insurance is basically, this is the type of insurance that covers any type of expenses of individuals and groups. Okay. Again, your premiums may vary, your benefits vary because it does depend on the type of plan that you choose to get. And most people choose their plans based on what they can afford. And that's well understood. Group health insurance, as I stated before, is an example of commercial health insurance. It's a lot less expensive than doing private health insurance. Next slide, group health insurance. How is it available? It's available through employers and other organizations such as labor unions or consumer health cooperatives. And basically, that's where your job that's offering you the insurance pays so much of the premium cost, and you pay a portion as well. Disability insurance. Okay, we know disability insurance is that insurance that gives you residual income in the event you become permanently injured, or you have a permanent illness or something that's temporary. Disability insurance is a lot different from just normal insurance. So with it being different, it usually requires a separate set of patient records. Disability insurance is, you have your long-term and your short-term, and most people choose, again, they choose that based on what they can afford, and it doesn't like pay your full salary, but it pays you a portion of what your salary would be. Now, there's a process that involves receiving disability benefits. So now this slide, the next slide, talks about what makes you ineligible. Okay, I have all of them listed here. And you can see the very first thing I have listed: claiming or receiving unemployment insurance benefits. Okay, so basically what that says is you can't be receiving unemployment insurance benefits and want your disability benefits as well. You can do either or, but you can't do both of them. Okay, I have other things listed here, such as committing a crime that result, like a felony, if you're getting workers' compensation, if you are in jail, prison, at home recovering, from a halfway house or something because of a crime that you committed, or you fail to go and have your medical exams done. What makes you eligible for disability on the next slide is if you've been unable to work for a significant amount of time, if you was employed during the time you was disabled, if you got the insurance cover, you can get the disability benefits. If you were under the care or treated from a licensed physician during the time of your disability, you qualify for the disability benefits. Processes a claim within a certain number of days after the individual was disabled. So, when disability benefits are to be paid out, it's just like any other insurance claim. You have to submit those claims as soon as possible. Okay. Only a licensed provider can complete documentation on your behalf as an individual or as a patient trying to get disability benefits. only a licensed provider can do such. Another type of commercial insurance is Blue Cross and Blue Shield. Basically, Blue Cross and Blue Shield is like one of the largest insurance companies we have in the U.S. There are reasons that a person could be disenrolled under this insurance plan, and I have a couple of things listed. One of them is just not paying your premiums. That's one of the things. Of course, if you're going through your employer, you don't have that to worry about because it's automatically deductible. But let's say, for instance, you were getting it or obtaining the insurance on your own, but you weren't paying the premium. You could be disenrolled from Blue Cross for that. Or if it has been known that you made some fraudulent statements on your application just so you can get a certain type of coverage. So let's say, for instance, you say you got this, you got that, just so you can get the lowest coverage or whatever, and then they come to find out that you falsified some information that can cause you to be disenrolled. The next slide is an example of what a Blue Cross Blue Shield insurance card could look like. And as you can see by this particular insurance card, they have PPO, so that's the preferred provider organization. Okay. Also, they have vision on this plan. They have dental on this plan. You can tell by the toothbrush. And then RX is prescription. So they have medical, vision, dental, and prescription. Looking at this, you can see the group number up there. It's the 6-digit number. The actual member ID is the number that starts with letters and numbers, and most Blue Cross Blue Shield plans usually start with letters, end with numbers, has the patient's name on there as well. His copay, when he goes to the doctor, OFC is office fixed copay, so that's going to be $10. When he goes to the ER, the copay at that moment is going to be $35. When it comes to the prescriptions, he may spend $5, $15, or $25 for his prescription. And of course, when you're the most generic, that's usually that'll be like the $5 one. So what are some services that Blue Cross covers? They do anything, they cover anything that's routine. I have those listed up there. So that's just routine. Hospitalizations, any lab services, x-rays, and surgical fees. Some other things that they cover are OB care, intensive care, newborns, and chemotherapy for cancer. Let's look at the next type of insurance we have is Medicare. So what makes you eligible for Medicare? Well, first of all, we know that that's for anybody who has at least who has worked at least 10 years in Medicare coverage employment. Is usually given to individuals who are 65 and older, or citizens or permanent residents of the U.S. And also it gives coverage to individuals who have ESRD, which is end-stage renal disease. Medicare has 4 parts. You have an A, B, C, D. So in Medicare Part A, another name for that is the Medicare hospital insurance. So this is the part of Medicare if in fact you are a Medicare patient and you're hospitalized. It takes care of anything that is inpatient critical care access. If a patient has to go to a skilled nursing facility, it takes care of that. If a patient has to be put on hospice or some other type of health care. Usually with the hospital insurances, the claim that is usually submitted for those is the UB04. Medicare Part A is, of course, for individuals 65 and older and those that's receiving Social Security or railroad benefits. And of course, it is a government program. Part B is also called Medicare medical insurance. This is the part of Medicare if you are a Medicare patient that takes care of outpatient services. Okay, so those are like your physician services, your outpatient hospital services, your medical equipment, and any other services that are not covered by your Part A. It usually requires MS 1500 form. You have your Part C of Medicare, known as the Medicare Plus Choice. So this type of insurance deals with your managed care and your private fee-for-service plans. It's pretty much an alternative to the Medicare Part A. So most individuals usually will go up on the Part A and B, and then you have a few that does the Part C Medicare Advantage insurance. Part D for Medicare is the part for the drugs or the pharmaceuticals or prescriptions. It involves fee-for-service plans. They have Medicare cost plans, and they also have savings account plans associated with them. So what is an ABN? An ABN is Advanced Beneficiary Notice. Always usually given to Medicare patients. You may hear it called ABN, so that way you know what it stands for. And so this is basically a document that's given to Medicare patients indicating to them that their insurance will not cover a particular test or procedure, depending on what that service or that procedure is. Patients need to sign them. They need to sign stating they understand that Medicare doesn't pay for this particular service, and then and that they will have to be responsible for whatever the charges are. Okay. ABNs need to be signed by the patient at the time of the services being rendered. So patients have the options of opting out, but if they agree that they want to have the test or the procedure done, you must make sure they have a signed ABN in their medical record, just so they can't come back and say the office didn't tell them and now they have this bill and they're refusing to pay it. So they have to understand, as the beneficiary of the Medicare insurance, if Medicare doesn't pay for the test, they're solely responsible for the charges. Okay. ABNs should always or also be signed in the event a claim for service could receive what we call Medicare medical necessity denial. So, if a service that a physician provides, if they feel that Medicare may deny it because of medical necessity, again, the patient should sign the ABN just to cover, just so the facility can cover themselves. So, Medicaid eligibility. Medicaid is not given to all poor persons or low-income families. Just because you have a low income doesn't necessarily mean or automatically mean you're going to get Medicaid. There's a whole lot of other things that are factored into that makes you Medicaid eligible. Every state has their own guidelines for this consideration. Medicaid works in conjunctions with CHIP, which is the State Children's Health Insurance Program. And basically what this does is allow states to have funding to help insure uninsured children. Okay, then we have workman's comp. Workman's comp is federal and state laws that require employers to make sure that if a worker is injured on the job, it's a work-related illness or injury, you have to provide workman's comp coverage for them. No, it's not going to be full coverage. However, it'll be pretty much a percentage of what your salary would have been, just so you can keep money coming in during the time that you're out and unable to work. The federal workers' compensation programs are the ones that is designed for the mines, individuals that work in the mine, plus Occupational Safety and Health Administration. And of course, that's OSHA, and these are the individuals that fight for us, healthcare workers, to ensure we have a safe environment. So for Mine Safety and Health Administration, it helps to reduce many of the deaths and injuries that occurs in the U.S. mines. It makes all of the facilities develop and enforce safety and health rules. And it also helps mine operators who may have special compliance problems. So, like, say for instance, if you're struggling with complying with something, you don't understand it or whatever, you have the Safety and Health Administration for the Mine Department there to help assist you. OSHA, as I stated before, fights for us, help to protect employees against injuries that occur from hazards in the workplace. So yes, they make it mandatory that health services have to provide us with a safe environment to work in. Employment Liability Act, that gives railroad, these are for railroad employees, protects them from employer negligence. Also, yes, so it makes sure that employers treat employees the way that they're supposed to treat them, and that they're not at risk for any kind of negligence that may occur. Then you have your State Workers Compensation Program. This is the program that pays out weekly cash payments and reimbursements for health costs. And usually this comes about for any work-related illness or injury that has been sustained on the job. You have to be eligible, of course, for workman's comp. And by that, I mean you have to make sure that the injury that occurred to you happened within the scope of your job description, and that there was not any horse playing or anything outside of your job description going on during the time of your injury. It has to have happened while you were performing a service for the employer at that time. You don't have to be physically on company property to qualify for workman's compensation. If you were injured while you were off the property, but you were still within working hours and doing a service for the job, they're still required to give you the workman's compensation for the duration of your illness or your injury. With that being said, you have to make sure that you complete a first report of injury form. This should be done the minute the injury happens, and it should be completed by the provider that actually sees the patient for the work-related illness or injury. This form should be completed and given to the State Workers' Compensation Board Commission, whoever the employer designated compensation person is, whoever the company is of the injured party, and of course there should be a copy in the patient's file, both in the doctor's office and on the job in the HR department. It should include things such as the name and address, whoever the employer is that the employee was working for, whoever's the immediate supervisor, what was the date and time that it happened, and it should provide a description of the site of where the injury occurred and any kind of onset of disorder, and it should be brief as far as details as to what happened. TRICARE is another type of insurance. It is basically the insurance that's only for active military members and their immediate family members. So, so this can involve anything: Army, Navy, Marines, Coast Guard, Public Health Services. Anyone that's actively in the military qualifies for this insurance, and it's for that person that's in the service and their immediate family members only. You have CHAMPA or CHAMPA. CHAMPA is for retired VA veterans. So anyone that has worked in the service and has retired, they get what you call VA benefits. And so this is a comprehensive health care program that is designed strictly for them. What makes you eligible? You have to either be permanently disabled from the service or permanently and totally disabled from the service. Or let's say, for instance, the individual was married, they died from that person, the wife or whoever the beneficiary was at the time, can receive those benefits. spouse or child of a veteran who has been rated permanently and totally disabled as a result can also receive the benefits from that. The surviving spouse or child of a veteran who died can also receive the benefits as well. Or the surviving spouse or child of a military member who died in the line of duty, but it wasn't due to misconduct. They also can receive those benefits. Okay, so that concludes the notes for chapter 6. So we move into chapter 7. Chapter 7 talks about different ways in which we finance health services system. So we know that health insurance is one way, but then there are also other different ways. So in the first slide, we've already talked about some of these programs: Feds, Medicare, the VA, military, Indian Health Services, Federal Health Services, and private health insurance. So we start first with talking about some different terms as it applies to expenditures for health services. One being cost, and I have the definition there on the slide for you, what we spend to produce a good or service. Cost containment is what we use to help control health services. Expenditures is the amount spent for health services, good or services. And pricing is the amount that's been charged for those services. So what causes us to have increased expenditures? Well, the very first thing I have listed is general inflation. And that's just simply the economy bouncing up and down. Medical pricing inflation can cause expenditures or can cause an increase in expenditures. Technology, as we know it, as the population grows, it can cause increase in expenditures. The availability of health insurance. And then, of course, you have our baby boomers or our elderly who's getting to the point where they require more services. Some other things that factor into increased expenditures is fraud and abuse, defensive medicine, and then we have our fee-for-service payment systems. So when we talk about fraud and abuse, that's basically where there were some intentional activities on the provider's part in which they were overbilling patients for services that was not rendered, or upsizing or upscaling the pricing on the services to get more revenue or something of that nature. Whatever it is unethical, it should never happen, and it is against the law. Most of the fraud and abuse that you find happening now usually occurs within Medicare and Medicaid programs. It is, and that's usually because that's our older generation who probably doesn't look at bills real closely. They probably don't have a clue. It's just easier to charge them, and they just pay whatever. So that's where most of the fraud and abuse usually occurs. If a person is found guilty of this particular crime, they do face what we call criminal, civil, and administrative sanction penalties. I put in this next slide some examples of fraud, and I won't go through them. They're listed right there in the slide for you. I also put on the next slide some examples of abuse, and again, I won't go through all of them. I have them listed in the slide for you. Defensive medicine. Basically, defensive medicine is where physicians increase the cost of health care because they do that to try to prevent malpractice suits, and it's a way for them to increase the cost of health care. But by them doing that, they expose patients to unnecessary risk. So basically what they do is just provide excessive care in a way to try to prevent malpractice suits. So it's like they do extra outside of the ordinary because they fear someone coming back to sue them to say, oh, well, you didn't tell me this, you didn't tell me that. So they figure, okay, well, let me just do extra. But the only thing about doing that is what I have in bullet number 2. You increase the cost of health care. That's number 1, because now patients are paying these outrageous bills for all these services that you've requested, and it exposes patients to several other unnecessary risks. So fee-for-service payments, This is basically where patients are charged a fee for the service or services that are provided to them. Basically, the way this happens is the physician agrees to accept the services, and if he or she agrees to accept the services, basically what they're saying is whatever your insurance reimburses me back for the services that I render to you, I'm willing to accept those particular services. Medicare also has something called OPPS, and this is called the Outpatient Prospective Payment System. And basically the way this system works is Medicare allows their patients to do either one or two things. And this only is for their outpatient services. They can either pay a 20% co-insurance amount for the services that were provided to them, or they may pay what we call a fixed co-payment amount, whichever one is less. And of course, the fixed co-payment amount is based on the geographical area. So I put an example in the slide for you. A patient by the name of Charmin Ultra underwent outpatient surgery to have her gallbladder removed. So the total charge of her gallbladder removal was $250. Now, according to Medicare, a co-payment amount for this type of procedure in the geographical area that she lives in is adjusted at $25. So what the office has to determine is, do we charge her the $25, which is the fixed co-payment amount, or do we charge her 20% of the charges? Which one is the lesser? Based on calculations, you would basically charge her $25 because 20% of $250, so we'll get calculated here and we'll do those calculations. So if we have $250 at 20%, that will give us $50. So there were actually, so $50 is more than the fixed amount of $25. So for that reason, you would charge her only $25. That's what she will pay for those services. And that's known as the OPS, the Outpatient Prospective Payment System for Medicare patients. So what are some rising costs that we're dealing with in the U.S.? One of the things that we're dealing with as far as rising costs in the U.S. is physicians and the amount of training and education that goes into that. When physicians have to go to different cities or states to practice medicine, it gets very costly, and even just the educational piece. They have to have, 7 to 10 years of education or longer. And then we're talking when they're in residency, a lot of them may be in residency 2 and 3 years. A lot of the drugs that physicians use to treat patients is another factor that factors into the rising costs in the U.S. Equipment and technologies, of course. And then, as I stated in a few slides back, our increase in aging population as well. So what are some new developments for the U.S. healthcare system as it applies to the financial piece? One is to make sure that insurers can't cancel coverage because of a simple mistake on your part, meaning that if you fail to do something minor, an insurance company can't just cancel you for that. They have to have reasons now to do that, and it have to be legit. Another development is being able to keep young people on their parents' insurance or whoever's their sole custody person up until the age of 26. And another development is making sure that individuals can't be denied benefits because of a pre-existing condition. So that concludes our notes for Chapter 7. So now we move into Chapter 8, Health Services Workforce. Okay. So in order for us to maintain health services, we have to have workers. We have to have medical professionals, those that have been trained, whether it's normal training or some type of specialized training. We have to have maintain a nursing workforce, and we have to make sure that we stay updated on any technology. So when I talk about the workforce or the health services workforce, the first thing that should come to mind is the healthcare team. Who are these people? These are people such as doctors or technicians or nurses who help diagnose disease. Okay. Others as part of the healthcare team may be your physical therapist, your pharmacist, your radiologist, or any other medical professional who are expert in their field of study, and they also help to treat disease and to care for patients with both physical and emotional needs. You also have, as part of the healthcare team, you have members of the front office staff, and you know these are the individuals, especially in the doctor's offices. They help schedule appointments, they help find medical records, they make calls, they greet patients, they verify insurance information. You have your nurses and your medical assistants. Their job is to do several things: take vitals, get patients to and from their rooms, give shots. They take messages, they relay messages, they record reasons for the visits. And then you have the PCP, or the primary care physician. Now, this could be an actual physician, doctor himself. It might be a physician assistant, or it could be a nurse practitioner. But either way, these individuals are the ones that come into the patient's rooms, whether it's in a doctor's office, a hospital, outpatient setting. They examine the patient, they talk with the patient, they help the patient to develop a plan of care for their services, for their healthcare needs, rather. If a lab or a test is ordered, then you have individuals that work in areas that performs the test. So we call them medical lab techs, or we call them radiology techs, technicians, or technologists. And then in another department, part of the healthcare team, is your billing department. And so we know what these individuals are for. They're the ones that handle all of your financial needs for your healthcare. Who are the physicians? Physicians are our first point of contact with health services. Okay? And so their job is to always make sure that they maintain a good rapport with their patients. And of course, patients are the clients. Physicians have to go through extensive training. They have to make sure that they're board certified for the services that they're performing. They attend school both in or can attend school both in public and private universities. And of course, their medical education is very, very costly. GMEs are graduate medical education physicians. Medicare is a major payer for the GME, and Medicaid is the second largest payer. This is the education that has to do with specialized training. Usually this is where physicians go off to medical school, and that's where they're there for at least 3 to 7 years or longer. Some are there for like 10 years. So I put a question in here: if the government pays for training, should the government have a say in where its trainees practice? I would say yes. The government is going to take care of the expense. They should have say in that. I do feel, though, that the one thing that I think they should do is allow the physicians that's going off in training, allow them the opportunity to at least go into an area that excites them more, or an area they have more interest in. I wouldn't have an issue with maybe the city and the state, but at least let them, like I said, choose the particular area that they want to practice medicine in. So is there a demand for physicians? Yes, and it increases daily. It is. There are demands for physicians in several U.S. medical schools, as well as different countries, because you have a lot of countries not as fortunate as the U.S. and don't have the resources that we have. So being able to have physicians that have went through specialized training to go into those particular countries that are poor and don't have as much as the U.S. is an awesome thing. So that is there is a steady need or increase in need for that. So who are the physician assistants? Basically, these are individuals. They are licensed physicians, but they work under a main physician. They can pretty much do just about everything a main physician can do, which includes diagnosing the patient, managing treatment for the patient. They can respond to emergency situations, and they can also prescribe certain types of medications to patients. Nursing, our nursing group, RNs, is the largest group. As far as our nurses are concerned, it's not nurse practitioners, it's not nurse managers, it's registered nurses, just plain old registered nurses. What happened or what has factored into our nursing shortage? One is school enrollments. And I can't really say that individuals don't have an interest in it. I just think that because the standards are so high, a lot of individuals just don't qualify to get in. Because nursing is one of those programs, for some schools they have a long list, takes a while to get in, and a lot of it is, I feel, is due to, like I stated before, the requirements to be able to get in, and the expectations. So because of that, individuals end up losing interest at some point, and they decide to go in other areas of the medical field, which leaves the shortage in the nursing field. Education, as far as nurses is concerned, they start pretty basic, like any other medical professional would in the medical field. A lot of them starts out as a CNA, and they just kind of work themselves up. But CNA is like the lowest level for nursing, because there's no licensure required for that or anything like that. So if a person didn't want to do CNA, or if they started CNA, they want to move up, the next level that they will move up is LPN. That usually requires at least 12 months of some kind of specialized training. That can be done at a community college, maybe a vocational program. If they want to go up from there, they'll go up to the third level, which is registered nurse. Usually, for most programs, it requires a bachelor degrees. There are some programs that do 2-year degrees for registered nurse. And then the next level of nursing past RN is the nurse practitioner. These individuals not only have the ability to work in various health centers, but they also have the ability to teach in nursing school. So our next set of medical professionals in the workforce is our pharmacists. So, just think, just ask yourself a question: what would healthcare be like without the pharmaceutical industry? What would it feel like for you if you had a headache and couldn't go and buy Tylenol, Advil, Aleve, Excedrin, Bayer, Goody powder? Just think if we just did not have drugs that help to treat symptoms and illnesses that we have, what it would feel like. These individuals have to have at least a 5-year bachelor's degree or be a 6-year doctor of pharmacy. This is for the pharmacist. This is actual physician himself. So you have to be licensed to work in whatever state that you're going to work in. Pharmacists have technicians that work under them. These are individuals that pretty much dispel orders and things for the pills. They kind of work the front office part. They help with checking patients in and out, giving patients their meds, double checking, and all that kind of stuff. But the pharmacist himself is the one that does the filling of the prescriptions. The next set of health professionals is dentists. Okay, so most dentists are in general practice. You have health services administration. These are the individuals that maintain the operation of the healthcare facility, of course. They have several functions. I have them listed on the slide for you. So what are some issues facing administrators? Leadership and flexibility. They have a hard job before them. Their job, as I stated before, is to ensure that everything is running smoothly. So these are the decision makers within the facility. So they have to make a lot of tough decisions. They have to make a lot of heavy decisions. But that's the job that, that's part of the job that comes with being an administrator. So this pretty much concludes the audio lectures for chapters 6, 7, and 8. This audio lecture will be uploaded in the student portal. The slides for chapter 6, 7, and 8 are already loaded in DocSharing for you as well, so that you may print those slides, and they're listed in DocSharing separately by chapter. Thank you.